So thanks, Trish, for making time for MSDI today. I'm Selina. My role at MSDI is as a Senior Research Fellow, looking at the links of health and global health with the Institute's work more generally. And I've only just started. I started about little over a month ago, pretty much as the COVID-19 effort was also beginning en masse in Australia. So we wanted to honour the World Health Day theme for this year tomorrow, which is honouring nurses and midwives and frontline workers. And I jumped on the opportunity because in my non-MSDI life, I'm not just working for the Lancet Medical Journal, but also have been working with a number of healthcare worker groups on social media around the country who are reporting problems with accessing masks, gloves and gowns for their general work. And it was made really clear, poignantly so to me, that even though I might have spent quite a number of years like you in the MSF field working in sometimes with outbreaks. In my case, I worked during the SARS outbreak in China, in fact, that some of the things that come very naturally to us in organising ourselves in the field don't necessarily come so naturally when you've never experienced this before. And I think some of the mental health challenges and logistical challenges are not too dissimilar. So I wanted to take this opportunity to have really more sort of reflection about what is the role of frontline workers and how do we really honour them? What does that mean? And I'll let you introduce yourself, but I know by reputation that you're an expert in climate change and health, and you've also been a nurse and a powerful advocate for that. So I really sort of welcome you to this conversation with me today.
Thank you, and thanks for inviting me. My name's Trish Schwedle, and I'm an academic. I work in, I've taught in nursing and midwifery for the past 5 years at Monash University, and now I'm doing my PhD in Germany on climate change and health. So specifically, I'm looking at climate-related migration and health. I've done some consultancy work with the Asian Development Bank, with the World Health Organization and with MSF on the topic of climate change and health, looking at it from a few angles, including the impact that it will have on humanitarian assistance. I've also done some research with Monash looking at how we teach climate change and health, or planetary health more broadly, to the health professions. And we're looking at how that's done across the Faculty of Medicine, Nursing and Health Science in 13 different disciplines. So it really is, as a transversal threat, it's really an opportunity for transdisciplinary education. So that's some of the research I'm doing there. And yeah, I'm involved in quite a few areas in terms of climate change and health with MSF as well. MSF's taking a more active approach now to integrating their work and thinking about how climate change impacts humanitarian assistance in a number of ways, from mitigation of humanitarian activities to adapting their operations to the new reality of climate change, and also advocacy. So that's what I'm working on at the moment.
Fantastic. How do you, as someone who's been a frontline worker, how do you see the role of nurses in global health in general, and the recognition for their role? My experience in teams is that in the field is that, and even in hospitals here in Australia and in the UK, is that often the organisation of wards and, in fact, flow and success of operations largely depends on nurse managers, ward managers, and all other staff, not, in fact, the direct clinicians. I don't know, I don't really see much of that recognition globally, including the fact that I think there was a report earlier this week that in the UK they hadn't specifically recorded the nurse deaths, or at least the person interviewed hadn't recorded the nurse health workers' deaths while they had recorded the doctor ones. And that just must feel totally insulting, I think, as someone from the nursing profession originally. My mother's a nurse. She picked that up too. So, yeah.
Yes, I've been a nurse for 15 years before I became an academic, and I teach nurses and midwives. So even though I'm moving more into a research area, I'm a strong advocate for nursing and midwifery. Okay. So nurses represent over half of the global workforce, and they the vast majority of healthcare worldwide. This isn't well represented in the media. Nurses, they're at every level of governance, management, and leadership. But yeah, they don't often step into the limelight and the media and say that. They don't do that as well as doctors do, I think. So sometimes their contribution is overlooked, I suppose.
I mean, I've heard stories here in Australia of different hospital units where sometimes it's actually been nurse administrators who have decided that the nursing staff, or perhaps it was another decision made, that nurses wouldn't receive the masks whilst the medical staff, the doctor staff, did. And that seems totally illogical and contrary to any sort of infection control, because when it comes to protective equipment and gowning, it should really be sort of universal for all the people in that unit. It just doesn't make sense. I mean, I don't know how much, how widespread that is, but in the last few weeks here, there've been increasing reports of not just shortages, but fear of shortages. And while it's been welcome that we've had more stocks being made available to Australia, no one I think on the ground is really sure at what stage it arrives to their state or to their particular hospital administration. And this is sort of basic procurement, I think. When I was speaking to Steph and Paris earlier, we were talking about how this is it should really just be a given, one, that we're a team, we're one, it's not just about the doctors, but two, that healthcare workers, it's one thing, to honour them, to clap for them at the NHS, or to honour them, with, now we've got an announcement in Victoria that we're going to have hotels will be made free for healthcare workers and hospital staff if they need to self-isolate, but really to protect them at the first instance, because they are our most valuable resource. And in China, up to known so far, 3,300 workers were infected. In Italy, something like, I think, 20% or more were healthcare workers, with a number of deaths. It's not good enough, but it's also, I think, a sort of dishonouring. And I don't know what it must be to be a frontline worker tomorrow. We're honouring, in a way it's honouring, but somehow it's a little bit disingenuous, because we don't have everything that we need to honour you with at the moment. And if in fact, even in some countries like USA, and I know there are reports also in Australia, there are threats from administrations to fire or to, dismiss or to give some form of punishment to workers who either do not follow the, who aren't seeing patients because they don't want to without the appropriate protection. And this is a real ethical dilemma, I think, and also a mental health dilemma, a mental health burden. So sort of just to flip on the side of, where this supply comes from and your work in climate change and health, I, in MSDI, we've had a few conversations with Tony Capon, the director, on how would we move to a more sustainable production of what I'm starting to call COVID commodities. last year I worked with WHO on this concept of common goods for health, in that, you know, vaccines and even in some environmental commodities, we call them commodities, but it's actual environmental rights such as fresh air, clean water, should really be considered common goods for health, because they form the basis of, you know, all good health. And that, in fact, perhaps, you know, masks and PPE are also part of that group too. And then the question goes to, well, how can they be sustained and made locally? I don't know, don't have the answers to that. I know for this year, we're certainly not going to get there for the need that we need globally, but it's something to think about. And perhaps, you know, this time that we're experiencing such a shift globally will bring us to different recognition or understanding of what can be lived differently. That would be, you know, the hope of many, I think, at MSDI. I don't know whether this, whether you've thought about this in the context of your research, or um, the, or whether it's even, you know, at that stage, because there must be so much, so many gaps in migrant and refugee communities that you're thinking of in your specific research on climate change and health. I don't know if you want to like share a little bit with us here.
Yeah, I might react to a few things that you've said. Firstly, about the lack of PPE for health workers and how that's distributed. I mean, healthcare is delivered in systems, and it benefits from a systems view, I think, as well, just like planetary health and climate change and health considerations. There is really a duty of care to health professionals. And when you say honouring health professionals, I just think, I mean, it's more than, and it's amazing that people are applauding from their balconies. I think it's the first time that we've seen that kind of recognition from the general public. Nurses and midwives and doctors are always the highest ranking in terms of respect from the public, but you don't tend to see that on a consistent basis in terms of the recognition, and until you reach a crisis like this, I suppose. And just on the lack of PPE as well, like, I think if you're a humanitarian and you work in resource poor settings like we have, it's kind of an extra commitment where you expect to be overwhelmed with demand and not have the resources that you need to provide quality healthcare. But when people in high income countries are faced with this, they're faced with decisions like reverse triage, where you have to decide who's going to get a ventilator. I think that can lead to some really serious moral distress, and the evidence does show that it will lead to PTSD and mental health in the future. So we have to think about protecting health workers' physical health as well as their mental health. And I think that's another thing that hasn't been addressed, is how do you protect your families? Like, I myself as an academic have signed up to go back to ICU in Germany. My number one concern is, or my criteria for going back, or what I need to be able to go back, is number one, PPE, and number two, I need to know how to protect my family. And I know there's lots of health workers all over the world that are living in their garages now because they don't expose their families to this novel virus. So, and I've also heard some interesting stories as well from humanitarian settings where people are really stuck. They don't have the PPE to provide healthcare safely, but they've got a duty of care to their patients, but they've also got a duty to care for their patients. So I'm hearing a lot of stories of people treating patients without PPE, nurses and midwives and doctors as well, which is really concerning. There's been lots of parallels made to wartime through this fight with COVID-19, and I think there's lots of ways that we can use that frame. It's really perplexing to me that we can't repurpose factories at the moment, for example, to mass produce PPE. So there's lots of, these high-tech discussions about mass producing ventilators and mass producing testing, but it can't be that difficult. I mean, it's paper and plastic. It really perplexes me how that can be an issue in 2020. And yeah, I think that if we honour health professionals, let's just firstly protect them and keep them safe, because we're hearing more and more nurses, midwives, health workers, pharmacists, the whole team, and we do deliver healthcare in teams, are getting sick, and some of them are dying.
Yeah.
It's really that serious.
Yeah, absolutely. Um, the um, the number of conversations I had even this last weekend with friends of mine in the US and UK who are seeing huge numbers of COVID case patients in their emergency and ICU wards was quite alarming, and the scenes they're describing are exactly uh, unfortunately like what we would see in sort of humanitarian either conflict settings or disaster, but without the command, without necessarily the organization or the preparation for it. I think you're absolutely right, about the PTSD. We're going to see quite mass, I think, across a number of countries' health workers, and problems adjusting back into life post. I hope there is a post. I hope it's not going to, continue longer. In terms of, making the mask locally and the production, I think there are, to their credit, there are certain companies and small groups already making masks. I mean, the irony is that Gucci, Yves Saint Laurent, and all these haute couture fashionista companies have decided to make them. But I don't know if you saw this Naomi Klein video 2 weekends ago on COVID capitalism. She was talking about how everybody's repurposing now for COVID. But even our social media platforms are, we don't know really. Is Zoom particularly private? I'm not sure. But I think there must be, hopefully, we can balance a new order between what is common, what is a common good for health, with the generosity, I think, of other companies wanting to chip in. But we need to have like some limit in terms of first providing for the people first before we go making excellent Gucci or Louis Vuitton masks. But, otherwise, we're just starting a whole new need for like an access campaign that MSF created back in 1999, and for which I worked for a very long time, in fact. It's an access for materials campaign now, but with a bit of a shift. WHO, of what I understand, has put forward a proposal with Costa Rica on a pool of rights for these commodities, and I think that's the first step. But as you know, everything takes really a long time to come from that level down to a mask that you put on your face before you go and see your ED patients. I think we just all have to work quite locally and advocate locally and protect ourselves and our networks locally at the moment, while staying really connected. Now that we've seen Europe and China and parts of Asia have crisis, we're starting to see the first few cases in really resource poor settings, like in indigenous communities around the world, but also in places like Nepal, India, where Arundhati Roy over the weekend wrote a beautiful piece, very sad about the hundreds of millions migrants exiting cities to go back to their homes and really not having any place to live. And then existing refugee communities like in Bangladesh with the Rohingya, who I've worked before with on a number of occasions. I just don't know even how to start to like think about what the impact that could have on really under-resourced health systems. And do you think that the double vulnerability of of the ones that are most affected by climate change and this would play any role in how a country responds to this current outbreak? I mean, it's not a very good question the way I've put it, but
That's all right. I know
any
what
thoughts
I
in general?
can talk a
Yeah.
little bit to that. Yeah. Well, MSF is seeing increased numbers of COVID in all settings, in all humanitarian settings where they work. And that is really the huge concern at the moment. While high-income countries are focused on their own domestic problems, which is also understandable because they're also overwhelmed, the next wave is definitely going to happen in developing countries. And that is really concerning because the types of measures that have been implemented in high income countries just aren't feasible there. Like when you think about working from home, I mean, most people living in poverty, if they don't work, they don't eat. There's no safety, there's no social security safety net for people, for those people. When it comes to washing your hands, well, if you don't have access to running water and sanitation facilities, how do you do that? How do you physically distance when you're living in overcrowded settings, in slums and in refugee camps? Also not possible. So these people are very, very vulnerable. And on top of that, they don't have access to basic healthcare, which MSF provides in a lot of these settings. So, you know, we're talking about increasing capacity of intensive care. Well, these settings don't even have oxygen. So, and on top of that, what we really don't understand is how COVID is going to interact with people that are already immunocompromised, people with TB, people with malaria, and kids as well with those illnesses that compromises their immune system, or malnourished kids. Like in high-income countries, we
Yeah.
largely kids are going to be okay, but we don't know what's going to happen. So, I think the attention when the first waves subside in high-income countries is going to turn to the global south. But before that happens, we really have to get ready. And our best chance is to prevent it happening. So we really have to amp up containment now and in developing countries. So testing, tracing and isolating. Because when it comes to treatment, there aren't many
Yeah.
possibilities in that setting. And MSF really is preparing for the next wave that's going to happen in Africa, the Middle East and Latin America. And the other concern for humanitarian organisations in preparing is it's really hard to move HR at the moment. All the borders are closed. It's hard to move humanitarian health workers into those settings. And everybody has a problem with PPE. So do humanitarian organisations. I mean, there's problems getting PPE out of European warehouses because Europe is now saying, well, no, we need that for us. So, and the other concern too that we can't forget is it's not just COVID. Like this is something that happened with the Ebola outbreak as well. Much more mortality and morbidity when a health system collapses from all the other illnesses and health issues that health centres deal with. So we have to think about maintaining other programs as well, because while you've got COVID going on, you've still got women with obstetric emergencies. You still have to vaccinate people for measles. You still have outbreaks and malnutrition, TB, all of the other programs. And that's the real risk, isn't it? When COVID to countries with fragile health systems, it's going to be a shock that will make them collapse. So the fragile health systems will collapse, and then we'll have a real catastrophe, humanitarian catastrophe on our hands.
Yeah. I want to say, thank you for your time, for giving to me today to have a chat on this. We'll have a little bit of a chat at the end as well. But if you had a message for frontline nurses and midwives today on World Health Day, what would it be?
I'd probably say, first of all, you're doing a fantastic job and your work is so important. It is the most important work that there is right now. It's not going unnoticed, and where people that understand the critical nature of your work, we're really getting behind you, and we need to fight to protect you so that you can look after other people safely as well, but also to look after yourself, I suppose, is a message, and your families as well, and speak out and advocate for what you need. It's I think nurses and midwives need to do that more. I don't know.
That's perfect. No,
I have to
thank
think
you.
about that a little bit more.
No, I think that's just perfect. I uh, I asked earlier the other two also to, you know, see, and they pretty much said the same thing. I think, you know.
Hi, my name's Stephanie. I'm a children's nurse practitioner. I worked with MSF many years ago now. In fact, I was in Uzbekistan for September 11, so it's aging myself a bit. And in fact, I was reflecting the other day that the feeling I have now is like that feeling being in Uzbekistan in that first few weeks after September 11 happened, with that huge feeling of fear and uncertainty, really not knowing what was going to happen next. There was a lot of threats about atomic bombs being dropped, and we were only 100 kilometres from the Afghani border at the time, so believe me, it was very close and very scary. That was an interesting role for me because unlike a lot of MSF roles, it was actually a health promotion and health education role. So I worked with a very tiny team throughout the Fergana Valley, training up local health staff to be health promotion and health education workers around primary health, really, and primary health education, because we found that population had very low health literacy. And it's interesting reflecting back on that to what I'm doing now. So I've had many years of being a specialist children's nurse in specialist children's hospitals, Melbourne, London, Perth. But for the last 3 years, I've had my own practice and I work in the community with children and families, particularly focusing on chronic disease in children and helping parents and children take control of their own health and be self-managing. So it's interesting how circular different parts of my role have been over the years, that each thing has linked into something else. And I think at a time like this during a pandemic, that awareness of health literacy for the whole community is really important because there's so much fear and uncertainty, particularly for families at home with their children at the moment.
Yeah.
So my name is Paris Ballet. I'm an infectious diseases physician, and I've spent pretty much most of my professional career doing aid work in various capacities with MSF. I've done about 16 missions. I started off as a field doctor in South Sudan and then ended up somehow doing a year and a half of research in Liberia on a malaria project. I then found that I enjoyed public health and epidemiology, so I ended up working as a field epidemiologist after doing a Masters of Public Health at James Cook. I was working in that capacity in the cholera outbreak in Haiti, and realised I needed to upskill, so went back, took a year off, went to London at the School of Tropical Medicine, did a degree in epidemiology, and my last 3 field missions have been working with the Ebola outbreaks in Sierra Leone. I was there right at the end, and then the last 2 Ebola outbreaks in Democratic Republic of the Congo. I finished my last mission about a year ago. I spent about 6 months doing preparedness in the provincial capital, 500 kilometers or so away from the epicenter in North Kivu. I've worked in meningitis outbreaks, and in Australia I've been locuming in various roles as a general physician, as an infectious diseases physician, and I've got this very strange overview of the health system in Australia. I think I've worked everywhere other than Melbourne. I'm currently based in Melbourne for family reasons, but I haven't been here for 15 years, and it's pretty much the only state other than South Australia that I've not worked in. So I've worked in in Alice Springs Hospital. I've worked in rural Queensland. I've been honoured to work in Tasmania, and I've come to the realisation that our rural health settings are really, really fragile, and I genuinely fear for our health system's ability to cope with a mass influx of cases in our regional centres, because we're so dependent on transferring patients or receiving support from tertiary hospitals in the capitals, that if those places are also flooded, I don't know how the flying doctors or medevac patients, you know, from Alice to Adelaide and so on, things that we're just used to taking for granted. So for this reason, it's very strange. I completely did not see this coming. I was working in Brisbane until February at a hospital, and I was involved in the very early stages of getting our hospital prepared for this. And I was very impressed by Queensland Health's proactive role in recognising that this was a legitimate threat when they only had a handful of cases at the Gold Coast. We stepped up our preparedness and set up fever clinics and things back in the end of January, first week of February, which I thought was quite good. But I'm now here sidelined, taking care of they don't consider themselves as elderly, but my older parents, who, like your grandmother, don't really see this as being something that will affect them because they're in good health, they're fit, they're active, and they think I'm freaking out, which I am. It's also very weird to be on the sideline for the first time because every single MSF honed reflex I have has me wanting to go into emergency mode. I want to start, I visited my general practitioner, there were no hand washing points, I'm in Ebola mode. I wanted to walk in, I was like, where are the screeners? Where are the people who screen me to make sure I'm not sick before I enter? There's a sign, it's hard to read, it's not in the right language. I walked into the GP clinic, they had no alcoholic hand wash, for instance, so they had nothing to disinfect your hands with. And in an Ebola setting, I've worked in a lot of resource limited settings. I've had to make decisions as a doctor where people haven't been able to live because I didn't have the resources I needed to keep them alive. So this is not foreign to me, except that it's happening in my very rich, well-off country. And so I see things that at the same time I recognize as very fundamental. I went to Bunnings and I bought jerry cans for my sister-in-law and myself, and they were looking at me like I was insane. I was like, well, you can put water in them. You can make a hand washing point. You can wash your hands before you touch that door, that door. This is what we do in Congo. And this transference of knowledge is lacking.
Yeah.
And it's frustrating me at the moment.
How do you see the role of nurses in particular as being recognised so far in the effort, nationally or globally? I mean, I see that in the UK that nurse deaths are not even recorded as such, if the media reports are to be believed as accurate recently.
Yeah, I think that's a very sobering and sad recognition of really how nursing is portrayed anyway. It has a very low media profile, and it's been an issue that a lot of nurses have been grappling with over the last few years. This is the 200th anniversary of Florence Nightingale's birth, so it's her birthday this year. It's the 20th year of nurse practitioners in Australia. This is a year we're supposed to be celebrating nursing and midwifery, and that's, oh my goodness, with COVID-19. In a way, I think it's going to bring nursing to the forefront because you cannot provide healthcare without a strong nursing workforce as well. But we need to speak out and be louder and be heard, and we are not invisible. We are really the drivers of a lot of the care that will be happening for people with COVID-19 and their families. And it's interesting, even in the last 24 hours, I know there's now a website in the UK recognising all health workers that have died because of COVID-19. And when I looked last night, there were 5 doctors, 5 nurses, and 1 health support worker already. So very sobering, but also recognising that it doesn't matter what your job title is, we're all in it together and we need to work as a team because we cannot do this on our own.
Yeah, absolutely. I think the most I guess taking reflective piece in my home of this is that I have an 80-year-old mother who is a nurse, a midwife, in fact, and she was she's Malaysian, and I don't know if you know this, Steph, but she was invited over here by Vivian Bullwinkle, the POW nurse who was incarcerated in Malaya at the time. And my mum worked at a local infectious disease hospital here in Melbourne, and she was saying to me the other day, oh, if I was any younger, I'd like to go out and volunteer, and all we want to do is kind of keep her inside and not let her have, be exposed, because she's so used to going out and doing her own thing. I feel almost guilty myself for not doing clinical work right now. But at the same time, I think there is a responsibility for those of us in public health or more sort of public facing roles that we sort of step up and communicate some of the issues that are facing frontline workers where they can't really speak out. And I think one of the areas that MSF does really well is témoignage, witnessing what is going on in the front line. And I don't know how that happens in countries where even in the Americas or UK and Australia, where it's difficult for doctors and nurses to ask for simple things such as materials when administrations, either hospital or otherwise, are asking them not to do that. And it almost is an ethical dilemma of, do you see your patient with the appropriate mask and gowning, or that is recommended by WHO, or do you not, and then have sort of this ethical duty that you're breaching. And I think both are in play, both the ethical duty of the administrators towards the healthcare workers, and also, our medical ethics as well. Going on from Paris's point of the absolute basic need to protect healthcare workers as we send them to see and fight against COVID-19. What do you see in your community? Because I also know that you work on guidances around the aged community as well. What do you see in terms of what is available or the communication that has happened to date in Western Australia?
So I've been asked by the health department to come and work with them in the last couple of weeks, because not too long ago, was a palliative care nurse for about 8 years, primarily at the time for children, but also became president of Palliative Care WA. And as a nurse practitioner, I have a lot of contacts with other nurse practitioners, and certainly aged care is an area where a lot of nurse practitioners are now working. My biggest fear is there's so much focus on the hospital system, and we're not really looking that closely at some of the other areas where we're expected to get significant pockets of COVID-19 outbreaks, like aged care facilities, residential units for people with disabilities, and even access to PPE in those areas is very different to the hospital settings. So I actually fear for quite a few of my colleagues. And a bit like Paris was just saying, that dilemma about not being on the front line, and what can you do? Like, I've completely flipped my clinical practice to telehealth. And it's weird, I'm sitting in my room here doing all my practice, which seems a bit distorted, and I'm really missing working with my children and their families face to face. But at the same time, I know I can offer more if I stay well, and I can support my colleagues better. And I've been talking to some of my nurse practitioner colleagues working in aged care, really getting to think about at what point, as a really senior clinician, who might be the most senior clinician going into some of these services, because they don't all have GPs, or they have GPs that can come and go. What is their role? Should they be doing face-to-face? Are they better off standing back a bit and staying well and being able to support more people over time? And I think that's some of those hard questions we need to think about, particularly when we know there's a lack of PPE or insufficient PPE for some people.
You're going to say something else?
Yeah.
Yep.
Just that I don't know that we know how much PPE we have. I don't know that there's been any transparency about this to the greater.
Yeah, I think this is part of the challenge that, no country was particularly prepared for this, but some countries in Asia, for example, China, Singapore, Hong Kong. I was in China when the SARS outbreak in 2003 happened. And I think there's a certain degree of community and administration trauma that also reflects in response to that this time, so that those administrations responded quite quickly, at least, by the end of January, early February. And I think for the rest of the world, it's been a sort of a difficult realization and figure out, so to speak. I agree with you in terms of the transparency and communication. It's not that we don't trust, the government and the experts advising them to give the best possible evidence-based policy, but it's as much about communication as we know, being ex-MSF field at national, global and field level, the communication is so important. And right now I'm involved in groups of doctors around the country who discuss on social media about, what, as I'm sure you both are too with your own networks, about what's going on and sharing evidence, but also sharing concerns. And an overriding theme is PPE and the misunderstanding of when it's going to come or what to use and which guidelines. Seems that a number of college guidelines are starting to be written around the lack, not around the best practice. And at a global level, there is a misunderstanding in terms of what the supply really is. There has been ample supply since Wuhan broke, because Chinese factories have upped their production capacity of masks, at least, to up to 6 times, reported by Clinton Foundation, the WHO orders for every month. And so there was capacity. And I think there have been orders which have been announced by the government, gratefully received, I think, by the medical community. But in terms of the pipeline getting down to clinics and communities and hospitals, it's not so clear. What would be ideal is an app, wouldn't it, or something that we could all look at, or a weekly update. It would give, I think, because it's not just about the infection control, it's also about your mental health and that burden that you have for going out, possibly unprotected, possibly infecting yourself and risking your lives, but also that of your family. And I don't know if either of you can speak about that as yet unspoken burden of the psychological impact, the disorganization, I would say, in some aspects has contributed to your experience in this period, and maybe that of your patients as well.
My biggest fear, I look after a lot of families who have a high level of adversity in their life. And I work with a few not-for-profits and non-government organisations to provide a ongoing, particularly parent support. And many of these families have limited resources, limited family support. They have histories of family violence, mental health problems. And I really fear for them at the moment, because a lot of their support networks have just disappeared, because they were having in-home support, they were having regular visitors. That's just completely stopped. I certainly fear for growing risk of family violence, and just how hard it is if you are already facing a lot of adversity and suddenly all your support networks have gone, or you didn't have them to begin with. How do you actually start from scratch? How do you put your children through an online schooling system if you don't even have the infrastructure in your house, let alone can you actually buy enough food? And I'm having mothers ringing me saying, I'm a single parent with 3 children and I'm scared to go to the supermarket because I've got no one to look after my children now, but I don't want to take my children to the shops because it doesn't feel safe. I don't know what to do. Fortunately, I can do telehealth with them, but the problem is so much bigger than that. And again, a bit like Paris was saying before, that whole, as a senior clinical nurse and a nurse leader with a lot of my colleagues in that same situation, there is a very high feeling of vulnerability and a feeling that if we are leaders and have a huge skill set, how do we protect that for us and for others, and yet not be seen to be not helping? It's a really difficult dilemma, I think.
Yeah, I certainly understand the vulnerability, even though it's perhaps in a different sense. I think the are co-opting back into a life which relies very much on social media and our connectivity through internet, means that we are pretty much subject to, you know, what comes out from media or from other avenues. We're not really, we are connected, but we're using different platforms and algorithms to connect.
I mean, a good example, I got asked to speak to a mother the other night by the agency I work with. They said, ring me at 5:30. Can you please ring this mother? Her baby's sick. I rang her. She only had a telephone contact. I couldn't video call her. She had a learning disability. She had a very sick toddler. And it was, I didn't know who she was. It was really hard to get a clear story from her, to decide how sick her baby was, to give her a really clear plan of what to do, and to get her to understand the plan. So we went through it about 5 times. We went through some scenarios. If this happens, do this. If that happens, do that. I got a call the next morning to say, from the agency to say, I was really glad you talked to her last night, because at 9 o'clock last night, she had to ring an ambulance and they went lights and sirens to the nearest hospital. And I was very relieved. I'd given her a bit of a safety net, because I didn't understand how much she understood from what I was saying. I couldn't see her face. It was very hard to, to make sure she understood where I was getting at. And also, when she was trying to describe her child's illness, when you've never seen them before in your life and you're just going on someone's verbal description, was really challenging. So fortunately, the safety net worked, but it was very sobering realising that just a telephone contact at the moment is all some families have to go with, and how that can be quite inadequate sometimes, but it's still all we have. But it was I felt quite sick when I got that call the next day. It's like, God, thank God she had understood to do that. But, and her child's fine, but she's in a very high risk group and it could have been a lot worse. And I was very relieved that had been the outcome.
Would you advocate for, as much as possible, doing things on like this sort of format where you can see your patients?
Oh, definitely. I've had another little, in fact, I rang another mother the other day for just a general parenting checkup. And she said she was worried about her baby. And I said, I'll put the baby up so I can see. And the baby had quite severe respiratory distress, nasal flaring, breathing really hard. I showed her an app on her phone and we could count the baby's respirations together. It was like they were 80. Like, okay, your baby's quite sick, I think, and, wasn't feeding very well and it was quite lethargic and had had a history of lots of breathing problems in the past. So, and she said, oh, but I can't get into a doctor. I can't find anyone who's available. I was like, it's okay. This is a consultation. I'm going to ring the local hospital, speak to the paediatrician. I think you need to go in. How about I review you in 3 hours? So we did that. We reviewed in 3 hours, again by video. So it made it very clear. She had a very clear plan of what to do in that time. And then I spoke to the paediatrician and he reviewed them in person later that afternoon. For a few hours and then went home. So the difference when we have the technology to use it, I think, is really important, and how challenging it is for parents who don't feel empowered or supported to know what to do. I know there's a big worry at the moment in the UK that children aren't going to hospital because there's so much fear about, and I'm sure it must be happening elsewhere in Europe, but there's been a bit of chatter from from the UK, and they're getting children presenting really late to emergency critically ill because parents have sat at home afraid to go to the hospital. It's a bit like Paris was just saying, not wanting to go to hospital because of the risk of COVID-19, but they're staying late with children who are septic and really unwell. And I'm sure there's going to be fatalities due to that.
I think the different vulnerabilities affect each of us differently. And I mean, I'm just going to admit something here. I mean, I haven't been going out to the shops for the last 2 weeks, and I'll tell you why. It's because I fear targeting as being a member of the Asian Australian community. And it's not that I'm, particularly at danger ourselves, but it's just things have happened. We've been spat at. And then there was this, I don't know if either of you saw that sign in Hawthorne that said, oh, you should look it up, it's terrible. I think it's been painted over now. Came up over last weekend. Says, shame on you, China. Go home, you yellow dog. There was an article in the ABC, actually, thankfully, a few days after, pushing back. And Dan Andrews, the Premier of Victoria, has been really, I think, very strong on pushing back on this. But it's, it's at a time where in the media there's a lot of discussion about the Chinese buying up a number of masks, a lot of masks for the Wuhan outbreak. And it's quite skewed in a way because it doesn't report on all the other things that are going on, such as the Chinese Australian medical community are pretty active right now trying to access masks for the PPE needs as well. And that's, it's a small thing in a way. Sometimes I think it's like, shouldn't even worry about it. But I think it's, real enough and out there that it does make different communities feel different, they feel more vulnerable than they normally would be. And Paris, I don't know if it's appropriate to mention, and we can certainly, not include it if you wish, but I know that, your family is Iranian and you, I don't know if you can comment on the experience there, or you have any knowledge of how that is being managed, or reflections, seeing it from your very unique vantage point of being a global health worker, sitting back here.
My family migrated. Well, we didn't migrate. My dad was an expat in India just a month after the Iranian Revolution in 1978, 1979. I actually grew up in India, and then we migrated to Australia in 1983 when Hawke was Prime Minister, and we had Goff's gifts and all those other things happening. I still have some extended family, elderly aunts and so on in Iran, although my family's scattered all over the world. I have family in America, in Canada, in Asia, everywhere. So my Iranian relatives mentioned something about the outbreak back in February, before the official extent was disclosed. They was aware, which was very interesting, a week before the government announced that they had cases. My aunt was telling us through social media that there were cases and it was being covered up. And it's weird because right now we are collectively freaking out. I had to stop watching the news because the amount of alarming, distressing images and reportage is just overwhelming. There's a 24-hour COVID channel run by Sky News, for example. I just can't. I was becoming non-functional, to be honest. And I had to stop because I can't do anything for my friends in America. I can't do anything for my friends in Italy other than show solidarity. I don't know what I'll be able to do for the people in the refugee camps in Greece, or the people in Syria, or the people in Africa, on the continent of Africa. I think South Africa's doing a great job, but the rest of the places, I can't do anything from here where I am right now. So I had to stop. So I've got all this alarming, horrible news on the, coming in, and we've got these incremental states of panic diffusing my society, or that's how I feel. And at the same time, my aunt and my relatives in Iran are basically saying, yes, we've got it. Yes, it's not under control. Yes, they're not telling us everything. But, I have to go to work. My aunt's in her 60s and she has to go and get a job. Otherwise, she doesn't have money to buy food. And she has a cough, and her cough got better after 2 weeks, and she thinks she's better. And so she's getting on with life. And so in a way, that's kind of not reassuring. It is reassuring because I figure if my relatives who are way worse conditions, with way fewer resources in a country that's not as lucky as us, are getting on with their lives, then maybe I should also calm down and, yes, do these things that are being asked of me, but not immediately imagine myself sick or imagine myself in a situation like Italy, and just basically get on with things. But it's this whole outbreak. I mean, it's still surreal for me. I wake up and it's probably because I'm not part of the solution yet. I'm on the sideline, and this is foreign for me, and I still think I'm not living this. The world looks the same. I look out the window, it's the same sky, it's the same vista, and then I turn on the news and it's all these dreadful, surreal things that I think are happening. And
it's like being in a movie, a bad movie.
It's a bad movie.
But it's not.
And I think once I'm involved, and I think for mental health purposes for myself, I'm not someone who can be sidelined. I'm not in, this is an alien situation for me. I need to be out there. I want to be out there. I'm looking for my MSF colleagues. I'm looking for my emergency coordinator to tell us to organize things. Our emergency coordinator currently is the Prime Minister and the Chief Health Officer and all the other people. And I'm looking for them to coordinate and do stuff. And I'm hearing a lot of different things, and I'm confused, and I'm not comfortable. I don't feel comfortable currently where I am and where we are. And I don't know I have more information about what's happening in the Congo. Because of their back-to-back Ebola outbreaks and the amount of scrutiny that was placed on them, ended up having an extremely effective public health response to infectious diseases emergencies, and so they publish an epidemiological report that's sent out to everyone. You can subscribe to it online, with all the case numbers, what's happening, everything nationwide. And they seamlessly transform that template to a COVID one. So I can tell you today that there were 7 cases of COVID in Kinshasa, and that the government's locked down this and this district, and this is the response. This is Congo, very resource limited setting. Yet in Australia, I go to the Department of Health website, and I don't have the up-to-date news. I have to go to Reddit and read newspaper articles to find out where the hotspots are and where cases are, and is there community transmission. And as an epidemiologist, this is very important for me, and this is key for me to gauge my level of safety for myself and my family, and I don't have that information, and I'm frustrated, and I will figure out a way to overcome this, because this is not sustainable. But at the same time, I'm very aware that we are a rich country. We are very well set up. We have lots of resources. It looks like we are, thankfully, being able to slow the rate of infection down, primarily, I think, because we're limiting and quarantining our international arrivals. But at the same time, I fear for my rural colleagues. I fear for my colleagues working in Alice Springs right now. I fear for we have coastlines full of retired communities, nursing homes, where there's always been a lack of medical and nursing care. There's been a massive lack of specialists in rural, and I don't know what I'll do if there's suddenly an outbreak in one of the 20 nursing homes in central Queensland or whatever. I'm very great. I know which places, which health systems are more challenged than others. I know Tasmania, the Northern Territory, I know these places. I'm very, very grateful that Tasmania has taken the very dramatic steps it's taken, because I know that Launceston, where I worked, has limited capacity at the moment to do, maybe I'm not meant to say that, but I know what the limits are. I know places where they need locums. Locums are needed in rural country Australia because of a lack of specialties, and these are the places where you don't want to have COVID outbreaks. But at the same time,
do you need to go?
I need to go. Sorry,
was that your exit strategy?
No, that's Brandon.
Okay. Sorry, Paris, I interrupted you.
That's all right.
I was going to say that we're probably going to be kicked off this Zoom in a few minutes anyway, because I timed it for a particular time. I can recall you, Paris, actually, in a different call. Are there sort of anything else you would like to share, both of you? And also, I know we've been discussing a lot of quite, dark things around our experiences and that of our communities around us in this time. But I mean, I really want to thank the both of you. I mean, you although, you know, Paris, you say that you're not particularly active and you're on the margins. I think by engaging, it is already in there, and you are going to be used. Well, I have no doubt. I mean, it's clear that, you know, this response needs all of us in different ways and in different capacities. And I really sincerely hope that, you know, you find the, you know, maybe it's month by month, not necessarily, you know, months by months, you know, the right place for the best efforts, you know, that you have, because you've got so much experience. And Steph, you know, you're right on the front line there, and I'm really glad that you're the one that's going to be writing those guidelines or helping and coordinating. And it's and I think the MSF family is strong. You know, we share an understanding of what it's like to be in uncertain times. For me, in a very perverse way, it's sort of familiar. And I know exactly what you mean by going back into that sort of emergency mode. I've been at it with my family and friends for months. They all think I'm a nutter. And I can't stop talking about it. But thankfully, I've got employers and supporters who really support me in terms of what I do, you know, outside of paid work. And I'm really grateful for that. So I don't know what your message would be to, you know, your last message, if you have the opportunity here on World Health Day, to, you know, nurses and midwives and
my message is that nurses and midwives, you're very important. We are all needed in this pandemic. And at some level, although we've spent all our lives putting our patients first, we must remember to put ourselves first, because if we don't survive this, we are no good to anybody. So PPE is vital, and you need to stand up and shout out if you don't have access to it, and find someone who can speak on your behalf if you can't speak because of where you work or who your employer is. I'm in a very fortunate position that I own my own business. I don't work for the health department except as a contractor, so I can speak out, but I know many, many people can't. And it's so important that we have transparency and that we understand what we can do collaboratively and working across all different boundaries, public and private, to meet this head on together.
Thank you.
Yeah. For me, all I can say from my time spent in the Congo is that we realized the value of transparency and community engagement. Community engagement was key in getting on top of the Ebola outbreak in the Congo. It was recognized by everyone as being, the lack of it as being a weakness. I would really like to see that happening more in Australia. And of course, every single breath we take, we should never take for granted. It's good health is a fundamental right. I'm blessed that my parents were allowed to come to Australia, where we have universal health care, where we have, I'm happy to pay as many taxes as I want to be able to sustain this and not be in the situation that my poor colleagues and my family are overseas, not just in Iran, but also in the United States currently. So please don't take healthcare for granted, don't take good health for granted. And health workers and frontline workers, which also includes very important people who do the cleaning of the hospitals and the infection and prevention control side of things, and the frontline workers, please don't make martyrs. Look after them. I'm not into heroics. I would like to know very provocatively what percentage of healthcare workers sick and dead are considered to be acceptable. I would say 0, but I would be grateful if someone would tell me what the economists have decided is acceptable, because I would like not to be in that statistic, and I don't want my colleagues to be there.
Yeah.
That's being me very provocative. You can take that out.
No,
after that.
Thank you. I don't even know how to end the recording, so thank you very much. Thank you so much, Steph. Have a good day.
I will. Good to talk.
World Health Day.
Yeah.
Ever, I think what a strange day. On a positive note, I think in a couple of days, if not today or tomorrow, the Ebola outbreak in the Congo should be declared as officially over, and I will celebrate by myself in isolation.
You can Zoom us in, Paris.
I
I'll
will.
celebrate with you.